My name is Jen, and I am the founder of Sober Livers. This meeting is being recorded for the first hour. Our second half hour is, I guess our third half hour is our reflections time. So I'll stop the recording at that point, and we will have open discussions so that we can do this openly. And so we'll continue to let people in, and I'm just going to go ahead and share a little bit about myself first, and then we will go into our hope agreements, and then we will introduce to you our speaker for the night, Dr. Shroff. And I'm very excited to have you. So my name is Jen, as I said, and I am the founder of Sober Livers, and we started Sober Livers initially back in January of last year is when the idea came to fruition. I was diagnosed with decompensated cirrhosis in 2018. I also had alcohol-associated hepatitis. I was given a 30% shot of living. And I was so ashamed that I'm sitting in the hospital room and I wouldn't even let my significant other call my parents. It was such a shameful event for me instead of what should have been a time of me trying to talk to my parents and share our love. And that could have been the last time that I actually ever spoke to them. And I felt a lot of guilt after that for a very long time because I thought, wow, I can't believe I almost did that to them. But the shame from having this condition and the stigma from having not only this condition, but I'm also a survivor of severe intimate partner violence. And that's when I did a lot of my liver damaging drinking. I drank socially before. I drank after 9/11 when I was traveling with my job. But it really made a big impact on me. And so stigma has really been something that carried with me for a very long time until I started to learn to love all of me. But it's still out there, and I still feel it out there. And as a group together with all of our advocacy leaders, we thought that this would be a great topic to bring to you. So I wanted to introduce Nancy to you, who is our chat facilitator. If you have any questions in chat, just please put them in there and she will try to respond to them. If it's medical in nature, we'll write them down, jot them down. And then the folks at our Whole Health Advisory Council, which Dr. Shroff is a part of, consists of both mental and physical health providers. We find answers to your questions and we'll get those questions those answers back to you. And you can also do that on our Facebook group, and I'll introduce Erin later in the program, who is our Facebook facilitator. So Nancy, why don't you go ahead and introduce yourself?
Hi, everybody. I'm Nancy. I am 9.5 years alcohol free. I almost drank myself to death, and I'm a little over 5 years post-transplant. And I love to give back. I volunteer for several organizations. And I've tried to educate myself about liver disease best I can because I want to know my disease. And I've done fairly well post-transplant. And I like to mentor other people post-transplant or anywhere on their journey, anybody who is struggling with alcohol from there to post-transplant. And I really didn't think I would live this long and be here now. My liver had messed my lungs up. I had hepatopulmonary syndrome. Pre-transplant, I was on oxygen for a while, and it got a little worse post-transplant. But I finally was able to get my lung strength back and do things now that I never thought I'd be able to do again. And I love waking up every day, and I love life. And I have bad days and rough times, but I try to practice gratitude every day, and I'm thankful to wake up each day, and I'm really glad to be here.
Thank you. Thanks, Nancy, so much. And we're so glad that you are here. I think, the life is such a blessing, and we're all still living, and some of us have our livers, some of us don't, some of us have a new liver, and we're just really thankful for just every single day. But you're right, there's difficulties along the way, and that's why we're here for each other, to let each other know that we're not alone. All right, well, I'm going to go ahead and share my screen, and we're going to talk about the hope agreements quickly before we get into this great program. And everybody, can you see my screen? Can somebody just tell me?
Yes, I see it.
Okay, great. And let me see if I can move this picture without without going through this. Okay. So here are group guidelines. Participation is encouraged, but please inform us in chat if you'd prefer to listen only. And then feedback, we like to share our opinions with each other. And so as we encourage what they call quote unquote crosstalk. So feel free to share about any experiences that you have that you think would help another person, but
Hey,
always
Jen.
use I statements. Yes.
Jen, we're seeing, I think, your presenter mode.
Oh, okay. Thank you.
No problem.
Let me do this. I appreciate that. Okay, now are you seeing it?
Yeah, that's better.
Okay, thank you. Thank you so much. Okay, so for example, I would say I had an MRI instead of an ultrasound because I had iron overload. If somebody was talking about wanting some information about whether or not they should have an MRI instead of an ultrasound. And medical advice, feedback is not medical advice. Consult your health provider before trying anything that we discuss here. So also please inform us if you're a medical provider. And confidentiality, ensure that you're in a private space and use headphones if needed. And please do not share details about this group outside of the meetings. We do talk a lot about personal health information, and I'm sure you don't want your information shared. So please keep everybody else's confidential. Cameras, I have an asterisk by this because we have a speaker tonight. We love for you to turn on your cameras because we believe it helps foster connection. But we are recording the first hour of this speaker meeting. So if you have a question or a thought to share and you want to be anonymous, please turn your cameras off before speaking. That way, when we're sharing this video with other people, your video picture will not be on there. But we encourage you, if you want to share your voice and share your face, we would love for you to do so because we are talking about stigma, and the best way to reduce stigma is for people to be talking about it, but only if you're comfortable. And then anonymity, if you wish to remain anonymous, you can just use your first name as your screen name and keep your camera off. And then inform the facilitator, Nancy, privately in the chat. And please share your ALD stage and transplant status. And then abstinence. While abstinence is not required to attend, please join our meeting sober. So if you are currently under the influence, do not participate verbally or in chat, except to contact a facilitator for support. Also, please provide your contact information for treatment resources if needed. And then politics. Sober Livers is nonpartisan. Our focus is on our shared experience with alcohol use disorder, liver diseases, transplants, and other health-related issues. And then finally, secularity. We're also primarily secular, but we welcome discussions on spirituality or religion as part of recovery following our feedback guidelines. We know a lot of people do have a spiritual awakening during recovery. And so if you want to share that experience, we are definitely open to that. And most importantly, we're here to learn from each other, offering compassion, empathy, and kindness. So take what resonates with you and leave the rest. And if y'all have any questions about these agreements, please let me know. And also some etiquette on Zoom. So if you could please, as opposed to raising your hand, because we do have several people here on the call, please use your hand raise mechanism that's located in your reactions button. Please feel free to share reactions. We welcome those. And let's see. And then that's pretty much it. Because we do have a speaker, I'll ask Dr. Hersh how he would prefer the interaction during the time that he's talking. But we would like for everybody in chat, please tell us where you're from and tell us how you're feeling today. Give us like 1 or 2 words about what is making you tick today on this beautiful Tuesday. Hopefully it's beautiful where you're at. It's been a little hot here in Colorado, which is where I'm at. And with that, I want to introduce Jack, have her give a brief introduction to herself. She's also one of our advocacy leaders, and she will introduce Dr. Hersh. And the squeaking you hear is my dog underneath my my desk. He found his toy. That's Artemis. So go ahead, Jack.
Thank you, Jen. My name's Jack. Originally from the UK, currently live in sunny California. Today I am 18 months sober, and I know it's a shock. And I was transplanted at Stanford at the end of June last year. And I'm really, really excited to introduce Dr. Shroff. So Dr. Shroff is a transplant hepatologist and associate professor of medicine at the University of North Carolina in Chapel Hill. He completed his medical training at Mount Sinai Hospital in New York and then Northwestern Memorial Hospital in Chicago. Upon joining facility in UNC, Dr. Shroff has taken a special interest in alcohol-related liver disease, ALD, and established a new multidisciplinary clinic called the Integrated Healthcare for Use, Alcohol Use, sorry, I can't read honestly, and Liver Disease iHeal Clinic. The iHeal Clinic pairs hepatologists with substance use counsellors and addiction medicine physicians to deliver comprehensive care for patients with ALD. Dr. Shroff is also active in professional societies, including the American Association for the Study of Liver Diseases, ALSLD, and the American Society for Transplantation, AST, where he actively collaborates with others around the United States on clinical research in ALD. I'll let you take it away.
Thank you very much. Okay. Well, Dr. Shroff, I'm going to go ahead and stop sharing my screen and let you go ahead and do your thing.
All right. Thank you, Jen. Thank you, Jack, for that introduction. Thank you, everybody who's here today, for allowing me to join this meeting. I've never been to a meeting like this. I imagine that it's a bit of a sacred space, and so I'm humbled to be part of it. Jen asked me to talk about stigma, and which I'm more than happy to be here to talk about. I put together some slides just because that's how we deliver information in the medical field. But I will not be talking for the entire duration of this hour, and definitely not even for a large part of it, because I think what I'm mostly excited for is to be able to learn from everybody here. This is a topic, stigma, which is frankly very hard to talk about for me, because I know that the experience of stigma is, I can learn much more from the experience of stigma from everybody here in this room. And so I really hope we can be sort of informal and interactive. And again, I really would love to hear people's thoughts and opinions if they're willing to share as we go through this. So let me just, I can share my screen. And I'll keep an eye on the chat and also on the raising of hands, so that if people have things to add, I can try to call that out. Or so the title here is Combating Stigma in ALD, the subtitle being The Problem and the Solution Lies Within. And we'll kind of jump right in. So I think when I talk about stigma, or when I try to understand stigma, my first question is sort of, what is it? And this sort of finger pointing, I think, is a encapsulation that of sort of what I feel people who are stigmatized must feel all the time, right? You, a lot of blame, a lot of finger pointing, and um, I've read a fair bit of work on stigma, and what I'm able to kind of understand about it is that it's sort of a social cognitive process that has a couple steps, a progressive process, if you will. Um, it seems like it starts with labeling, right? So labeling someone with a description. In this case, the unfortunate label oftentimes is this person is an alcoholic. In that process, what happens is you create this out group, right? You've got this identifier that now is plastered onto somebody, which puts them in a bubble of an out group. And with that label comes this deluge of stereotypes, oftentimes negative, that are associated with that label. And in particular, in stigmatized conditions, those negative stereotypes can be things like irresponsibility or being weak-willed. And what that causes is this sort of status loss and discrimination, whether it's intended or not, definitely happens. Then these concepts start to become internalized. And that's step 3 here. And that's self-stigma. And then finally, and it's not that this is exactly a stepwise process, a lot of these happen kind of in tandem, but a lot of this becomes almost formalized. Again, potentially not intentionally, but because of the perception that many people harbor, those perceptions start to kind of make their way and seep into the rules and the policies and the systems around us. And you get these formal discriminatory policies, intentional or not, which is called structural stigma. And then it's kind of a cycle. It perpetuates the labeling and the negative stereotypes and so on and so forth. I think this is notably a little bit different than how stigma occurs or manifests in other conditions. Alcohol is very specific and is different from even other mental health conditions, for example, because blame, I think, is a central part of this with alcohol. So, for example, schizophrenia, right? There is certainly stigma around having schizophrenia, but we don't necessarily blame people for it. And I think that's a big component of this that I kind of wanted to touch on today and see what you all thought about this. But going into the different types of stigmas that I just mentioned, this table shows a couple things here. So you've got 3 forms of stigma: public stigma, which is kind of the labeling and the stereotypes; self stigma, which is the internalization; and then structural stigma, which is kind of when it becomes more formalized on a system level. And in this table, this author, who's a psychiatrist out in Germany, who's done a lot of work in stigma in the alcohol-related liver disease realm, Professor Shomeris sort of outlines how these stigmas take action and what the result is. And so I'll go through each of these individually, and then would pause and kind of want to see if the group has any thoughts. But public stigma, again, these are sort of negative or discriminatory other attitudes that others have about people with ALD. And what it leads to is this devaluation of the self. This person is lesser because of their alcohol use. Importantly, I think this is super important, when it's anticipated to happen, right? When someone anticipates that there's going to be stigma from the public, what it leads to is secrecy and avoidance. And it's shown that these attitudes can actually delay the seeking of help. So then patients with liver disease related to alcohol, we see, come later and later and later in their disease course when things are very, very far gone, which is very different from all the other liver diseases that we see. We typically get referred patients at much earlier states in their disease process in other liver diseases compared to alcohol. And part of that is this stigma, I believe. And what then happens is that the healthcare system looks at that individual and says, well, they waited so long and it's their responsibility for, not seeking help earlier, and they're to blame, right? And you can see how this cycle kind of perpetuates itself. Self-stigma, as I mentioned earlier, is the negative attitudes that one harbors about one's own self. So when it gets enacted, what happens is someone has less self-efficacy, right? What is self-efficacy? It's this capability to, conquer things. It's this ability to sort of rise above the odds. How able will one be to reduce alcohol use, to become abstinent? How able will one be to do anything that they would like to do? That's self-efficacy. It leads to shame. And when we anticipate the possibility of self-stigma, what happens oftentimes is problem denial, right? I don't want to feel that self-stigma, so my defense mechanism is going to be to minimize the problem. If I don't acknowledge the problem, then I don't feel the stigma associated with that problem. But again, problem recognition is the first step oftentimes on the path to recovery. And if there's a built-in mechanism that forces us to deny the problem, then that's an issue. And then structural stigma, and definitely this is an area I see a lot, the way healthcare providers sort of allocate resources with transplant, things like a 6-month rule, which we've thankfully started to do away with, but it's been kind of a big part of transplant for many, many years, and happy to talk more about that if anyone's interested. So that's the sort of forms of stigma. What I was going to do today is kind of go through each of these with kind of specific examples that I've seen, and pause with each one to kind of ask if other people want to chime in as we talk. So the first one being public stigma, which is the sort of negative stereotypes about other people. Let's see here. So that person should know better. So I wanted to just give a quick example here of these are all examples of things I've seen in my time in various places. I won't give much context to try to preserve anonymity, but in this example, we had seen a young woman who was in her 30s. She was actually a healthcare worker. She presented to an emergency room a year earlier than us seeing her with jaundice. She did drink heavily, but the notes from that emergency room visit are very vague about why she was jaundiced. There was a thought that maybe it was from a recent antibiotic or maybe an infection. It did not clearly say that they thought that her jaundice was due to alcohol, but the emergency room providers do write in their notes that the patient should likely cut down her alcohol use because it may be contributing. So then doesn't seem that anything really happened after that, but 6 months later, she was seen by a surgeon as an outpatient for ongoing jaundice and for some abdominal pain. It's pretty clear in retrospect that this was all just a severe form of liver disease related to alcohol use, but the surgeon at that time told her he thought it might be the gallbladder. So he schedules her for a cholecystectomy, which is a gallbladder surgery to remove the gallbladder. Cholecystectomy happens and she goes into shock because it's not her gallbladder, it's her liver that's sick the whole time. And a surgery like that is exceedingly dangerous for someone with that severe liver disease. So she gets transferred to our hospital in liver failure, getting sick from the gallbladder surgery. We're a transplant center, so the question is she a transplant candidate? At the point that she got sent to us, she was really sick and septic from an infection related to the surgery, and so unfortunately was not going to be a transplant candidate at that moment regardless. But when she was brought up at the center that I was at the time, the discussion did come into the discussion of her prior alcohol use did come into play, basically of like, well, if she gets better from this infection, would we consider her for transplant given the history of the alcohol use? And the center I was at the time was not kind of, forcing patients to be abstinent for 6 months. There was definitely some willingness to kind of transplant people, or, who had just sort of quit drinking if so it wasn't necessarily that, but one of the people in the room said, well, that person should know better. She's a healthcare worker. And even if the emergency room providers didn't really make it explicit, like she should know. And that really was jarring for me to hear. Because why do we hold this person to that standard when we're not holding the providers who took care of her for the past year to that same standard? That emergency room provider who did not make it as clear as they should have. That surgeon who is responsible for this person's downfall because they took out a gallbladder in someone that they shouldn't have done. Why don't we say that person should know better? And I actually spoke up at that point, and it got a little contentious. But I think my, you know, I'm it's hard to kind of speak up in these scenarios, and I'm not perfect by any means, but I know for sure that when I see something like that, you need to sort of voice, your opinion, and stand up for the people who can't stand up for themselves. So um, anyway, so that's an example of public stigma that I've seen, one of many. I don't know if people are willing to kind of share their thoughts, or even if anonymous, and not even just about this case, but if they have any other sort of thoughts about public stigma and um, how it manifests, how they've seen other people experience it.
Is there anybody that would like to share information?
Are you
Stop
asking?
sharing, so we open this up. Yeah, go ahead. Sorry.
Oh, for me, Hannah S. Anyway, when my liver disease, which I didn't know I had, got really bad, I couldn't go number 2. So I went to the hospital because I thought I was constipated. And of course, I brought my little swig bottle with me in my purse. And my husband was sick of my crap and my drinking. So he told the nurse. And then the nurse from that point had a scowl on her face, didn't take me seriously, told me to go home, take Miralax, and stop wasting their time. So as soon as she found out I was drunk, I was immediately blown off. And I knew there was something wrong. I didn't listen to her. I went to Einstein, Montgomery. I'm in Pennsylvania. And they immediately rushed me to Einstein, the hospital in Philadelphia, and diagnosed me. But yeah, that nurse blew me off. So I've been there. And that was what I was afraid of coming out. I probably still wouldn't have come out, except that my body called me out because I was not functioning anymore. It was breaking down. But that was just scary.
Thank you for sharing that.
Sure.
Yeah, I've
Anyone else?
definitely. Oh, hi everybody, Chris. I've had to speak about this a bit, and I've found in say the last 5 years that I've been trying to get sober is that in emergency rooms is where I find the most stigma. And whether it's from getting triaged last, having to wait. I've also found the medical professionals, in my experience, when entering an emergency room for an alcohol related incident, that I do get met with a lot of, we have bigger problems than you, we don't want to deal with you. As far as getting like just put in the hallway when there's plenty of rooms. I went to an emergency room, I think it was back in not that long ago, 2019, and I was in full seizures. And I had tried to quit cold turkey. My wife found me in seizures. She rushed me to the emergency room. And yeah, they literally just put me in a hallway and told her to go to the corner store and get me a bottle of alcohol. And they discharged me once she got back with a bottle of whiskey. And, it's those sort of situations where it would have been nice to at least see a social worker, get some treatment, know about detox. I didn't know anything about the medical information behind quitting cold turkey. And, I'm just somebody trying to help myself. And I found that it was met with just a lot of judgment, and a lot of stigma. And, it wasn't like, we're dealing with 20 gunshot wounds right now, we don't have time for you. It was just, and it's happened on multiple instances where it was like, this was your fault. You did this to yourself. We're just going to let you rot in the hallway. And, luckily I have a lot of supporters with me, like my wife, my sister, people in my life that would advocate for me, and, pretty loud people that made sure I was seen and seen with care. But, a lot of people don't have that. So, that's my experience, and something I wish I could change.
Thanks, Chris. Hey, Jack, go ahead.
Thanks, Jen. Yeah, absolutely. To to echo what Chris said, really. It's, you know, I was definitely met with disdain, and again in that ER setting, you know, and it really starts with that first step, because it will make people much more reticent to seek help in the first place, which is what you were saying. In my circumstance, I went to the hospital, and it wasn't any of the nursing staff. It was actually the doctors that were, you know, not very compassionate. The woman who told me, she's like, well, didn't you notice you were yellow? And I'm like, well, actually, I didn't. She's like, oh, well, and you're going through withdrawals. So, and again, as Chris said, you know, no signposting, no social worker. And like, I was in hospital following that interaction for 2 weeks, and there was plenty of opportunity for that, and you know, it just didn't happen. And so I think that there's, you know, very, very much that when you did it to yourself, when actually you've made a step to get help, and then there's no forthcoming.
Yeah, I hear it. I hear you all, and I see it happen often on my end too. So I'm sorry that you've all had those experiences, and appreciate you sharing.
Nancy, would you like to share something? Yep, you're on mute.
Okay, there we go. I find it frustrating that I know it's not their fault. When you go to the emergency room or you go to your primary care physician, they're not liver experts, but they try to diagnose you anyway instead of calling in an expert. And then if they know it's from drinking, they're able to refer you. If you have a heart problem, they send you to a cardiologist. They have a whole list of them. If you have anything wrong, they refer you to somebody. But if you have a drinking problem, they just say, you got to quit drinking. That's what they did to me. And I knew that I guess it's on my own to go out there, but they could have given me a list of resources, perhaps local resources, instead of maybe just say, call AA, see if you can find an AA meeting. Everybody don't want to go to AA. And I think they should, because there's so many cases of liver disease these days, I think they should be more equipped to help us drinkers who caused it ourselves. And I think that in the emergency rooms, if they think something might be wrong with our liver, I think they should call in an expert. They're really good at sending people home and saying you got 48 hours to live, or you're going to be fine. And then people go home and say, well, doctor said nothing's wrong with me. My eyes are yellow, my skin's yellow, I'm throwing up every day, but you know, doctor said I'll be fine, because they're not a liver expert. I think they should, all the doctors should be more equipped to handle us some way, calling in the experts and having some resources for us, because there's a huge population of people just like us, and we need help, and most of us want help, and we don't know where to turn to find it. I'm done
I agree.
ranting now.
Let me, if it's okay, go on, because there's going to be opportunity for more discussion. Okay. The next stigma I was going to talk about was self-stigma. And this is something I've heard more than once. I don't want you to evaluate me for a transplant. I don't deserve one. Give the liver to someone else who's more deserving. There's not many things you can hear someone say that's more heartbreaking than that. Not that it really matters if my heart breaks, but you know, still, I don't want to have to sort of sit and face someone. I mean, you know, it's hard to face someone who kind of feels that way about themselves and to know what to say. And again, would love to hear kind of everyone's thoughts here. But when we talk about that model of that stigma that I sort of showed earlier, and how self-stigma develops, I think one thing that was kind of interesting to me in reading about this in the past is someone once described something called the why try effect. So it's like the self stigma creates this feeling of like, why should I even try? If I'm weak willed, if I'm irresponsible, if I am fill in the blank, then how will I do this thing that I'm supposed to do? So why bother even trying? And then again, I think I mentioned this in the beginning, but sort of the built-in automatic defense mechanism to try and avoid self stigma is to not identify with the problem, which it makes sense in some ways, but being able to kind of come to a recognition of what you're dealing with, I have to imagine has to be one of the first steps on that journey. And if you can't get there because of the things that the society around us, perpetuates and then kind of helps infiltrate into our own minds and create that self stigma, then where how does one even sort of start to kind of get through this? It seems insurmountable. Um, so this is definitely the sort of pinnacle of that self stigma that I think I've experienced. Again, opportunity to sort of stop and see if anyone wants to share anything about that. A little bit different because it's about it's internal and about ourselves. But
Nancy, go ahead, and then we'll have Amy. You're on mute, Nancy.
I'm terrible about that. I see that a lot. I see a lot of people saying they don't want a transplant because they don't deserve one. Or that if they get the call, they're going to turn it down. And what I kind of like to tell people, or they got a liver and they feel guilty for it, is I don't know what kind of higher power they believe in, but things just sort of happen for a reason. And there could be a liver sitting there and it's not a match for somebody else that thinks they're more deserving. If they get that call, it's because it's a match for them, whether they deserve it or not, whether they feel that way or not. It's, it's just like fate, sort of. It's perfect for them. It's not perfect for somebody else, or they would have called somebody else.
Thanks, Nancy. I appreciate that. Go ahead, Amy.
Hi. Yeah, I was diagnosed with liver cirrhosis, liver failure. We're looking at transplant probably into the year. And my first initial reaction was like, I don't deserve this. Like, I'm the one who messed up. I'm the one who made these choices. Even though I recognized through therapy it was me dealing with trauma in a bad way. But, I went through that. And what was brought up to me by my team, I'm working with Stanford right now, is when a person puts themselves on a donation list, it's meant to go to somebody to save their life, no matter the circumstances. And otherwise, what's going to happen is that organ going to be unused and just go to waste, as to say. So it really, after talking with them for a while, it really motivated me more to prepare and accept my consequences, and the fact that if I do get this liver and there's a match, not to feel too bad about it. I still feel bad about it because for me, I need a full liver. I can't do a living one, like when they can take a little bit from someone else. So I'm like, oh my God, someone has to die in order for me to get this. But, people die for all kinds of reasons. And I was shared the science behind, well, you might get a liver that's not 100%, but medicine has come so far that, we can work around these certain things and it could still be a match free and still work. So yeah, I relate to that.
Thank you. Thanks, Amy. And thanks for being here. I appreciate you coming. Go ahead, Chris.
Hey, I just yeah, it's interesting. I got diagnosed at Stanford as well. But I want to bring up something that was really important that was just mentioned, is that that portion pre-transplant where you're faced with the reality that somebody else has to die. And I think that that kicks in a lot of the self-stigma, at least for any decent human being, where I know my wife and I sat contemplating. I would go to AA meetings crying, bringing up the topic. And, you know, now post-transplant, I definitely have some survivor's guilt. But, you know, those moments where you're like, okay, it's such a brain scramble where you're hoping somebody dies, but you don't want them to die, but you're going to live if they do. And then you're also faced with everything else going on where it's, you have to be sick enough to need it, but you have to be well enough to make it through it. You know, there's so much going on mentally. And I thank you for this group and some others, but you know, it's so hard to find support for those things like self-stigma that we go through during the entire transplant. I think it's one of the most confusing, hardest brain scrambles that anybody has to go through, is navigating this entire journey of a liver transplant, especially due to alcohol. That's my 2
Thanks.
cents.
Thanks, Chris. I appreciate that. Nancy, did you have one more thing to add to that? Oh, you're on mute.
I'm sorry. I'll try to get better with it. I want to add to what Chris said about the self-stigma and getting a transplant and you wanting someone to die, but you don't want someone to die. But it's forever. It's even after your transplant. We still have to defend our right to live to some people. Kind of sucks. But giving back and living a good life is a good way to show those people that think we don't deserve to live, that we do. But yeah, it's forever, that stigma. It doesn't even go away after you get your transplant.
That's hard. That's hard to think
Mhm.
about. Thanks. Yeah, that's actually a topic that we're talking about for our next meeting, and we can talk about this in reflections as well, is how do you handle that question, why you deserve a liver, right? And how you handle those things. So yeah. Dr.
And
Hersh?
yeah, I mean, I'll just add from my point of view, sort of sitting in the chair that I'm sitting in across from, you know, my patients. These are things that if one is going to get through them, I imagine, as you said, Nancy, takes long time or maybe can take forever. And yet we're faced up against this kind of ticking clock sometimes when people get sick and have limited amounts of time to get to a transplant. And I struggle a lot with that. Because on the one hand, this is not a process that can be rushed. And then on the other hand, we're sort of trying to rush it because we're forced to. And it's not that it needs to be completely fixed prior to a transplant, but as we said, some of these stigmatizing behaviors on the public side and then the self-stigma do impact, you know, I'm sure the likelihood of someone engaging in treatment or continuing or wanting to kind of confront things or be around other people and all that stuff. And so those are sometimes things we do need to happen prior to transplant for some people who need transplant. And yeah, I don't know, no answers necessarily, or if there is, someone share, please. But these are definitely things that I think about. Oh, okay. I'll just continue on then. So structural stigma is probably the one area that I can speak most to because it's sort of on our end in terms of what we do. And I wanted to give an example here. I don't know how many people know this. Maybe a lot do. I don't know. But when we're evaluating patients for transplant, a very commonly used scoring system that we use is called the SIPAT, SIPAT. It was actually developed at Stanford. And it measures sort of 4 domains. It's not meant to be specific to patients with liver disease from alcohol. It's sort of just meant to be a psychosocial evaluation tool. But it measures readiness, social support, psychological stability, and then a history of substance use. And so each domain, there's multiple questions within each of these 4 domains, and then each domain is scored. And the higher your score is, the kind of quote unquote worse someone's psychosocial profile is prior to transplant. As many of you who've gone through the process know, transplant is a complex process, and there's a lot that comes into play afterwards. And it's really important that we help stabilize people from a social, mental, psychological perspective, so that we're putting people in the best positions for success after transplant. And so this is one of the tools that we use to kind of gauge things. Because the domains are built so that substance use history is one of the 4 domains, naturally, individuals whose underlying disease is related to substance use are going to have a higher overall score, right? The questions underneath this domain of substance use are going to be scored a little bit higher for people who have had a history of excessive substance use compared to someone who has not. So a question is whether it's valid or fair to compare the CyPAT score of a person with alcohol-related liver disease to that of a patient with, let's say, something like autoimmune hepatitis. You know, if you look back at how this CyPAT score was developed, again, it was not developed to be kind of used specifically for patients with alcohol or other types of liver diseases. It was sort of a broad-based tool. And so on an objective level, I think no one ever indicates that this should be used in a comparative fashion, like this person has a CyPAT score of this and this other person has one of this, so we should choose the person with the better CyPAT score. That's not how it's intended to be used, and that's not how anybody would suggest to use it. But human nature is, you know, what you expect to do and what you sort of actually do are 2 very different things, right? And we are influenced in ways that we don't realize. And so there's I don't have any evidence to say that this is what happens, but I suspect that there's a subconscious tendency to see a score and then to say to yourself, well, this is a very high score compared to the other people I've evaluated before, so it may bias us for or against certain people inadvertently. And also, I will say that most people don't use the score as a single sole reason to, you know, list someone for a transplant or not list someone for a transplant. It's just one piece of a much larger puzzle. And in fact, part of this evaluation is more to figure out the areas in which we can support a person during and after a transplant, rather than to put up a barrier to transplant. But again, how does it actually impact our decision making on the ground, on a day-to-day basis, in the subconscious level, I think is open for discussion. And I suspect that there's a little bit more of a way in which it biases us than we'd like. So I also want to spend a moment on terminology, because this is part of structural stigma and also all the types of stigma. And many of you are probably familiar with this, if not all, but you know, it's always been called alcoholic liver disease, right? And I'm interested in etymology and kind of word origins. And so what is alcoholic when you use it in the word alcoholic liver disease? Is it being used as an adjective, which would be defined as something resulting from or associated with excessive consumption of alcohol, right? So you can describe the liver disease using the adjective of alcoholic. The liver disease is related to alcohol. But is that really what's coming across when we use that term? Or are we using alcoholic as a noun? A person who's addicted to alcohol. I think if you spend a few minutes to just kind of think about it in your mind, you can understand why many people think it's a very benign thing to say that. Well, I'm just describing the liver disease. I have another patient with autoimmune liver disease, so I say autoimmune liver disease. It's just it's a descriptive term. I'm not describing the person, but again, the labels are the labels, and what you mean and how the connotation are 2 different things, right? What makes this worse, I would say, is that historically, we've actually called the counterpart of this disease, non-alcoholic fatty liver disease, or NAFLD. The name has recently changed, but that's a very new thing. And Jen knows this very well because of the foundation that sort of researches fatty liver. But the point is here that there's actually a stigma associated with the non-alcoholic term for those patients, so those individuals. But in our case here, what I think the stigma that happens is that you create a contrast between the two people, the two types of diseases, so that if I'm labeling someone as non-alcoholic fatty liver disease, I'm making darn sure that that person knows that you're not this other person who has alcohol-related liver disease.
Mhm.
You're us or them, right? So by trying to make it clear that there's something really that people can have that's not related to alcohol, you are inadvertently stigmatizing, I think, those who have liver disease related to alcohol. I have non-alcoholic fatty liver disease, so please don't confuse me with them. You know what I mean? And I think that's a big problem. Now, this name has changed. It's now called metabolic dysfunction associated steatotic liver disease, which is an absolute mouthful. But the idea of steatotic liver disease is the medical term for fatty is steatotic. So it's fatty liver disease essentially, which can be caused by alcohol or by metabolic issues. And so in some ways, we've hopefully started to move a little bit away from that stigma that's formed by the terminology. And we're trying to call the alcohol related form alcohol associated or alcohol related. And so in a way, you're no longer pitting one group versus another by their name. You're just allowing one group to be one group and another group to be another group. I think that's really important. And I know a lot of people feel that you're just mincing words, but I don't feel that way. And anyway, so I'm not going to really go into this but there's someone who looked at kind of how stigmatizing languages are used on websites and liver transplant centers across the country. And the point is that stigmatizing language is used frequently. So we've got a lot of work to do on our end, and there's a lot of structural stigma I could have talked about in more detail. But I thought, what can we do about this? It's a good way to end here. So first of all, this is exactly, I think, one step in the right direction for me. Again, I can't emphasize enough. I spend a lot of time thinking about this, and still I feel that I put myself under the microscope first and foremost because I want to make sure that I'm doing whatever I can to try to be as least judgmental and stigmatizing as possible. And being a part of this with all of you is really a huge part of that for me. So thank you. Learning from one another. I think promoting education on a peer-to-peer level, right? So those in sort of similar shoes, helping those in other similar shoes. So whether that's me sort of, working with the physicians around me or the nurses I work with, working with other nurses or, et cetera, et cetera. I think on the structural level, training our liver providers in addiction medicine, training in non-stigmatizing approaches to individuals, changing terminology, as I just mentioned, trying to remove rules that are unjust or stigmatizing, rules, policies, procedures, things like that. Being critical of what we're doing and having a change mindset, I think, is very important. And then just empowering the people around us and our peers to sort of speak up and to kind of feel like they can, voice their opinion. I think those things chip away and move the needle slowly but surely. This is a very broad and high level list because I don't have all the answers, but just some additional thoughts. And yeah, that's all I had. So
Dr. Shroff, that was excellent. And I especially love the language talk because that is something that is near and dear to my heart that I speak to a lot. And I like the us and us, not versus anybody, because I really want us to feel with liver disease that we're all in this together, regardless of how we got our liver disease. And that's important for us to remember. We have about 5 minutes left. So I know that some of you may have some questions. Dr. Shroff, can you stay with us a few minutes after I run through some of these so
Yeah,
that we can?
I'll be about 5-10 minutes, if that's okay. Yeah.
Yeah. If you don't mind, just so people can voice their opinions and share some things with you. I just have a couple more slides just to share with you guys. We are looking for folks to help us evaluate our new platform that we were talking about the last time that we came together. And I'm not going to put this in form. I'm just going to do it like this here. Can y'all see my screen? What are you seeing right now? Do you see we are growing our advocacy team?
Yep, we can see it.
Okay. All right. So we need some meeting platform evaluators. And so we're going to be having a meeting towards the end of September. And so if any of y'all would like to join us to help us evaluate our Hey Peers platform, send me an email with the subject line advocacy team. And we'll get you the information that you need to sign up with the Hey Peers site and see if you're available to do a small group meeting where we'll just have a small group discussion, open discussion with all of us to evaluate this new Hey Peers platform. And then the other thing that we're looking for is anyone who knows X and TikTok. We do have one volunteer right now. Chris has volunteered to help out, but we could probably always use someone else. So if you are great at either of these and would like us to help spread the word about sober livers in the HOPE program, also send me an email and let me know that you'd like to do that. And so that's Jen Jones at soberlivers.org, and I will put that in chat. And the other thing I wanted to share with everybody is the American Association for the Study of Liver Diseases has an annual meeting that they call the Liver Meeting. A few years back, they started inviting patients to this meeting, and it is a great opportunity for patients to get involved. There's patient sessions. We're doing one on one of those new terminologies that Dr. Shroff was talking about. It's called MET-ALD. So it's actually a combination of people who have metabolic dysfunction with alcohol-associated liver disease, because that's something that has existed for a pretty long time, and we're finally diagnosing it. And so that's going to also help to hopefully remove some of that stigma that exists. So that's one of the patient sessions, and I'm also going to be talking at a cirrhosis session. But there's lots of other sessions that are there. And then you can also join if they're online. You can join us virtually, or you can join us in person at San Diego. And if you want more information on that, you can go to aasld.org for more information. Again, I want to thank Dr. Shroff for providing us with an in-depth look at stigmas as they relate to people like us with liver diseases and transplants due to alcohol. As you witnessed, Dr. Shroff, we are deeply affected by this complex systemic issue, and I hope we have started a conversation that will continue to reflective solutions. Physicist John Archibald Wheeler said, "As our island of knowledge grows, so does the shore of our ignorance." I don't know about you, but I like the beach and think it's time to jump in and make some waves. So let's start by joining us at our next meeting, which will be October 8th at 7 p.m. Eastern, where we'll be having open discussions on topics of y'all's choosing. And get ready for an exciting month for celebrating and raising awareness for National Liver Awareness Month and Sober October. So be sure to engage with us on Facebook this month. We'll be posting tidbits about these exciting campaigns. And remember, you are not alone, and we look forward to continuing this journey with you. Amora Fati.